All right, let's put you in the hot seat. Today, we're diving into one of the most intense tests any surgeon can face, a consultant-level viva exam. The scenario? A life-or-death penetrating trauma. We're going to walk through the critical decisions that mean the difference between life and death, passing and failing.
Okay, so here we go. The clock starts now. A 30-year-old man is wheeled into your ER. He's got multiple gunshot wounds. This is your patient, and every second counts.
Let's look at his vitals. Right away, you can see this is bad. His blood pressure is way down at 70/50. His heart is racing at 133 to compensate. He's barely getting enough oxygen, 80% on a high-flow mask, and his GCS is only 12, which means he's not fully conscious. There's no doubt about it. This man is in profound hemorrhagic shock.
The examiner looks at you and asks that first big question. You're the surgeon on call. All eyes are on you. How do you approach him?
The only way to deal with this kind of chaos is with a system. You don't panic, you get organized. And that means we start with step 1, the primary survey. You have to stick to the ATLS protocol, especially when the pressure is this high. So, what's the game plan? You follow your ABCs, fast. First, protect the spine with a C-collar. Then, airway. Get him on an ambu bag and prepare for intubation. Breathing. Listen to his chest. Circulation. Get 2 huge IV lines in and start pouring in fluids and O-negative blood. While all that is happening, you're drawing blood for all your baseline labs. This is the dance of trauma resuscitation.
Okay, so your initial moves are working. Kind of. His blood pressure comes up a little to 90/70, and his pulse drops to 110. You get a moment to breathe. But don't get comfortable, because just then your exam reveals a brand new critical finding.
And right here, this is where the real test begins. We've hit a critical pitfall. The next decision you make is literally the one that separates a pass from a fail. This is a big one. While you're listening to his chest, you hear it. Or rather, you don't hear it. On the right side, nothing. Absent air entry. It's a simple, quiet finding, but it's screaming that something is terribly wrong.
So the examiner leans in. What is your immediate next step? Do you ask for a chest x-ray to get a pretty picture and confirm your suspicion? Or do you trust your clinical findings and put in a chest tube right now? Let me be clear, there is only one right answer. If you say chest x-ray, you've just failed. It's a deadly delay. The patient could die in radiology. The only answer, the life-saving 10 out of 10 answer, is to immediately insert a chest tube.
And bam, the second that tube goes in, you get your confirmation. A gush of 1,000 cc's of fresh blood pours out. You've just diagnosed and treated a massive hemothorax. You didn't need a picture, you needed to act. You just saved his life. For now. With that immediate fire put out, we can now move on to the next big decision. Is it time to go to the operating room? To answer that, we need to assemble the full picture of just how badly this guy is hurt.
So you get on with the secondary survey. You find the 2 holes on his front, chest and abdomen, but you know better than to stop there. A careful log roll reveals 2 more exit wounds on his back. You do a quick fast scan with the ultrasound, and it's positive. That means there's blood in his belly. A chest x-ray, which is appropriate now, shows he still has some blood and air in his chest. The only good news, his pelvis seems to be intact.
But this fight is far from over. Even with all the fluids and blood you're giving him, his pressure starts to tank again, right back down to 80/50. What does that tell you? He's still actively bleeding somewhere inside. There's only one place to go from here.
The decision is made. You're heading to the operating room. The examiner nods. Good call. Now how do you prepare?
A great candidate has this checklist memorized. You're calling the OR to have blood and blood products ready and waiting. You need a laparotomy set for the abdomen, a thoracotomy set for the chest, and definitely a vascular set because you have to assume a major vessel is hit. Get bowel staplers, broad-spectrum antibiotics, a tetanus shot, and tranexamic acid to help with clotting. You have to be ready for anything.
So now we're in the OR, and we're about to hit on a really advanced topic, a key concept for any trauma surgeon, damage control principles. This is all about knowing when to stop operating and why that decision can be the thing that saves your patient's life.
So imagine this. You've opened his belly, you're trying to control the bleeding, and then your anesthetist leans over the curtain and says, hey, he's had 15 units of blood, he's severely acidotic, and I can't keep his pressure up. That right there is the lethal triad of trauma. It's a death spiral.
And that's your cue to switch gears. You have to move to a damage control laparotomy.
Forget about fixing everything perfectly right now. This is a quick and dirty, life-saving surgery. The goals are simple. Stop the bleeding, stop any gut spillage, and then get the hell out. You can come back and do the pretty repairs later once he's stable enough to survive it.
So how is it done? It's 3 simple steps. 1. Control bleeding. You pack the abdomen with sponges to tamponade the bleeding. 2. Control contamination. Find any holes in the bowel and just staple them shut for now. No fancy repairs. 3. Temporary closure. You just close the skin, leaving the fascia open to prevent pressure buildup. Then you get him to the ICU so he can recover.
Well, he makes it through that first surgery, but the exam's not over. Now we move into the final questions, which are all about managing the tricky complications that are bound to happen after a case like this.
So a couple of days later, he's much better, he's stable, so you take him back to the OR, you do your formal bowel repair, and you close him up properly. Things are looking good. But then, on day 5, a new problem pops up.
You're on rounds, and you see that the surgical drain you left in has put out 300 cc's of this watery, pinkish fluid. That is not normal. The examiner looks at you for the last time. What's your differential diagnosis?
A great candidate's mind is racing with possibilities. What could this be? 1, it could be ascites, just fluid buildup from the massive resuscitation. 2, it could be the thing you dread the most, an anastomotic leak, meaning the bowel repair has failed. Or 3, it could be urine from an injury to the bladder or ureter that was missed in the initial chaos. You have to consider and investigate all 3.
You've done it. You've managed the shock, made the tough calls, survived the OR, and worked through the complications. The examiner leans back. Final question. What is the single most important principle this whole case teaches you as a surgeon? And the answer is this. In a dying patient, physiology always trumps anatomy. You have to stabilize the patient's body first. You have to fix the shock, the acidosis, the hypothermia before you can even think about a perfect anatomical repair. That is the lesson that saves lives.